Hello everyone, and welcome to this webinar on how to tackle AMR in Europe's healthcare facilities. My name is Jean-Yves Tenuic, and I serve as Pharmaceuticals Policy and Project Officer at Healthcare Rotterdam Europe, where I oversee a work program on pharmaceuticals in the environment and its impacts on the development and spread of antimicrobial resistance, or AMR. I will be the moderator of today's webinar, and I will explain to you the agenda in a few minutes. We have over 90 people registered for this webinar, with participants coming from all over the world, with countries as diverse as Australia, India, Iran, Mexico, New Zealand, Uganda, Ukraine, and the US, which shows that there is also a strong interest from outside Europe in this topic. The webinar will include presentations from 3 speakers. First, Ana Paula Coutinho-Reze, who is Technical Officer at the World Health Organization Regional Office for Europe, who will give a scene-setting presentation on AMR in healthcare facilities in Europe and share the WHO views on how the issue should be addressed in relation to the WHO Global Action Plan. Then we'll have Walter Zink, who is Senior Physician with the Infection Control Program at the University of Geneva Hospitals, who will share his views on efficient and cost-effective IPC measures in order to address AMR in healthcare facilities. And finally, we'll have Thomas Müller, who is Environmental Coordinator at the Aarhus University Hospital, who will present a pilot project he has been running with the Danish Technological Institute to neutralize drug-resistant bacteria in hospital wastewater. After the 3 presentations, I will present the key highlights of a report we are publishing today that identifies best practice from 6 hospitals from across Europe on how to tackle AMR in Europe's healthcare facilities. Before we dive into our topic, I'd like to give you a short introduction about who we are and what we do at Healthcare Rotterdam Europe. In a nutshell, Healthcare Rotterdam Europe is the European part of a global non-governmental organization with regional offices in the US, Europe, and Asia. Our mission is to transform healthcare worldwide so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in the global movement for environmental health and justice. We have over 140 members in 29 countries of the WHO European region that include European hospitals, healthcare systems, healthcare professionals, local authorities, research and academic institutions, and environmental and health organizations. We bring the voice of healthcare professionals to the European policy debate about key issues, and we have 5 key work programs. Our Safer Chemicals work program aims to reduce chemical pollution and exposure from the European healthcare sector. Our Climate Smart Healthcare program aims to decarbonize the European healthcare sector and increase resilience to climate change. Our Sustainable Food program aims to increase sustainability of food production and consumption in European healthcare. Our Safer Pharma program, which is the one I'm leading, aims to reduce the presence of pharmaceuticals in the environment and exposure to AMR. And finally, our Sustainable Procurement program aims to reduce the negative environmental, social, and health impacts through European healthcare procurements. We work on these areas in close cooperation with our global network of green and healthy hospitals, the GGHH network, that is made of more than 1,200 members representing 36,000 hospitals and healthcare centers. So thank you very much for listening to us. I will now give the floor to our first speaker, Ana Paula Coutinho-Reze, who is Technical Officer at the World Health Organization Regional Office for Europe. Ana Paula works on the Health Emergence Program for the WHO. In her role, she supports countries with implementing and strengthening of infection prevention and control programs at both national and facility levels, as well as with outbreak investigation and response. Ana Paula works closely with the WHO European Antimicrobial Resistance Working Group, where she leads activities in the area of infection prevention and control, IPC, and linkages with antimicrobial resistance. Ana Paula, the floor is yours.
Good afternoon and good morning, everyone. My name is Ana Paula Coutinho-Reze, and as Jean-Yves introduced me, I work for the WHO Regional Office for Europe, in the area of infection prevention and control. I work for the WHO Health Emergencies Program, and I also contribute to the work of the Antimicrobial Resistance group in the WHO Regional Office for Europe. So I've been asked to give you a short presentation on how these global initiatives from WHO, they have an impact in terms of tackling antimicrobial resistance in Europe's healthcare facilities or any healthcare facilities. So I hope by the end of this very short talk, you understand that the work that we do together with our colleagues in WHO headquarters that is based in Geneva, and our work here also at the regional office for the European office here in Copenhagen, Denmark, has an impact to everyone working in a hospital. Myself, I had the opportunity in the past to work in an infection prevention and control service in a hospital that was a very large hospital, 1,000 beds in the city of São Paulo, Brazil. So by now you already noticed that I have a strong accent, so apologies if some of my words that doesn't come so clear, so I will try to stick to the text that is on the slides. So WHO published a few years ago the Global Antimicrobial Resistance Action Plan. This Global Antimicrobial Resistance Action Plan has 5 strategic objectives. Number 1 is about improving awareness and understanding about antimicrobial resistance. So this has, a context of dealing this at the community level, at healthcare level, and also at the political level. Another strategic objective is about strengthening knowledge and evidence base on AMR, on control of antimicrobial resistance. The third strategic objective is about reducing incidence of infection. And here is in my area of work where I am more connected, because this is where the infection prevention and control area of work really kicks in the global AMR action plan. The fourth strategic objective is about optimizing the use of antimicrobial medicines. And this is not only for human health, but it's also for animal health. There are countries that they are very, very much advanced in controlling the use of antibiotics in the animal population, while other countries are very, very, very much behind. And the fifth strategic objective is about developing an economic case for sustainable investment. We all know that antimicrobial resistance became a very interesting topic that everybody likes to talk about. Everyone likes to pay some attention on it, especially when we are, with our families or we are talking with our friends. There is always someone talking about, yeah, I heard about this new bug that is resistant to everything. However, what we are still struggling is how really to control the use or to control the resistance at facility level, at the level where the patient receives care. In terms of global activities, we have, I just listed some of the most important ones. So we have the World Antibiotics Awareness Week, we have the Global AMR Surveillance System that is called GLASS. We also have a Global Antibiotic Research and Development Partnership, that is the GARDIP. WHO in 2016 published the core components of infection prevention and control programs. We also have a global priority pathogen list of antibiotic-resistant bacteria, which is really, really important at national level, and also to make sure that AMR is really put up in the agenda in terms of politics. And we also have an updated essential medicine list that is always, it's always important to ensure that certain antibiotics are included there. In terms of regional activities, we have something slightly different, but with some specificity. We have the World Antibiotic Awareness Week. We also have the European Antibiotic Awareness Week that is led by the European Center for Disease Prevention and Control, which, our office also works together with them in this activity. In Europe, we have surveillance of antimicrobial resistance network called CESAR. It's Central Asian and Eastern Europe Surveillance of Antimicrobial Resistance Network. We also have Antimicrobial Medicines Consumption Network. That is the network that is making surveillance for antimicrobial consumption. We have activities in the area of infection prevention and control. It's in regards to the implementation of the core components. So they are also at the regional level antimicrobial stewardship courses and some activities in terms of tailoring AMR programs, which I will talk to you in a second. So here is just to give you an illustration that we have. So these are two very large networks. So it's the Antimicrobial Medicines Consumption Network and the Central Asian and Eastern Europe Surveillance of Antimicrobial Resistance Network. So these networks, they also complement the existing European networks in this area. So for the Antimicrobial Medicines Consumption Network, there is they complement to the ESAC-net, that is the European Network for Antimicrobial Consumption. And for the CESAR network, we complement the work which is done by EARS-net, that's the European Network for Antimicrobial Resistance. And we also have a global AMR surveillance system. And some people will say, but well, we talk so much about surveillance, why so much duplication? Well, because as you know, resistance or pathogens, they do not need visas or invitation letters to cross borders. So these are issues that are of concern at global level. So I think that something that is happening in a hospital, in a city, in a country, may in certain circumstances be of concern at international level. So the global AMR surveillance system, it's a much more expanded network. They are looking into a larger number of pathogens. They're also looking into different types of specimens. While the CESAR network is only looking at blood, the specimens that are under surveillance in glass, in the global AMR surveillance system, also includes urine, feces, and other types of specimens. So to avoid double duplication, double reporting of data from countries to WHO headquarters, so we agreed that countries that are providing data through CESAR, this data is immediately sent to GLAS. So there would be no need for another reporting. So this information is shared, but it's just a subset of the information that is set. There is a feature in GLAS that I would like to bring your attention that is very, very interesting, especially at the facility level. It's called GLAS EAR. It's Emerging AMR Reporting Framework. So the International Health Regulations points out that if there is an event that is considered unusual, unexpected, may pose serious public health impact, and has international, there is a substantial international risk of international spread, and may have impact in terms of travel and international trade. So these are events that are considered a public health emergency of international concern. So if we think about the way that some resistant mechanisms, they were discovered, they were reported, and they further disseminate across the world, we could have said that perhaps those were events to be considered public health emergency of international concern. However, at that moment in time, member states, countries, and state parts, they were not ready to use the existing tools. So now WHO headquarters has developed a feature in GLAS that countries or hospitals can even identify if there is a new mechanism or an emerging or a re-emerging mechanism of bacteria or resistance can be reported through this platform that is called glass ear. In order to avoid that national authorities are not made aware of, occurrences of these emerging or re-emerging mechanisms, WHO always deals with national authorities. So that's this to make sure that in a country, so if there is a new mechanism of resistance happening in a hospital that was identified in a lab, we want to make sure that the national authorities of that country is aware of that. Another aspect that I think it's very interesting that we are quite advanced here in this region. So I think it was 3 years ago, we developed the Antimicrobial Stewardship online course. It's you can find in the Open WHO, which is a platform where you find lots of training materials. So this is the most popular online course that we have in the Open WHO. There are lots of individuals that took the course across all over the world, and every time that there is a new discussion or a new topic regarding antimicrobial stewardship, colleagues can be connected again through this using the Open WHO platform. So it's quite interesting. It's giving, it's a very powerful tool to reach out, anywhere, anyone, anywhere, to make sure that at least they understand the principles, the guiding principles of antimicrobial stewardship. Is not the objective of this online course is to define what should be in an antimicrobial stewardship program in a hospital, but it's at least is to make sure that individuals are aware of the guiding principles of an antimicrobial stewardship program. In terms of infection prevention and control, we are in 2016, WHO published the guidelines on the core components. So there are 8 core components for infection prevention and control. 6 core components, they are relevant at national level. So these are the core components number 1 for IPC programs, core components number 2 for IPC guidelines, core components number 3 for IPC training education, core components number 4 for healthcare surveillance of healthcare-associated infections, core component number 5 that is about multimodal strategies, core component number 6 that is about monitoring, audit, and feedback. At facility level or at hospital level, we are recommending the implementation and the application of the 8 core components. So in addition to the 6 core components that I already had mentioned to you, we also talk about the core components 7 that is about the workload, staffing, and bed occupancy. And core component number 8 is about built environment, materials, and equipment for infection prevention and control. So some people always, they like to ask us which one is the most important core component. So our answer is always that the core components, they are equally important. So in the absence of a program, it's very difficult to implement a guideline or to monitor adherence to a certain IPC measure. So without the right number of healthcare workers, it's going to be very difficult to implement, let's say, properly some contact precautions. Or in the absence of knowing what is the rates of healthcare-associated infections in your hospital, so it might be a bit difficult to understand how the multimodal strategies are actually working for the, to decrease a certain type of infection. So these are all 8 core components. They are equally important. They are interconnected. We do understand that it's very difficult to have all these core components in place. However, we see that it's very important that colleagues understand that it's not a pick and choose. You're not going to the supermarket and say, well, today I'm going to have vegetables. No, it's definitely all the core components are important. And you may start with one and then start with another core, then go to another core component, but at the end of these strengthening infection prevention and control programs at the hospital level or at national level, it will reach the point that you say, okay, so now we went through all the core components. The last, the other program that we also have here, it's something called Tailoring AMR programs. This is quite interesting because it's looking more at how we can actually target behavior change. Because we already know that there are some bacteria with their own types of mechanisms for resistance, but we also have to acknowledge that healthcare workers, they also have their, I would use the word, the resistance mechanism to change behavior. Right? They know that it's needed to, to wash their hands, or they need to comply with certain type of antibiotic therapy, that they should not use this type of antibiotic, when to do microbiology tests. So they all know this, but there is sometimes when, although knowledge is present, behavior is changed. So we are also looking into this aspect to see what could be the drivers that are preventing behavior change. So we have some pilot studies in some hospitals, and we also have a guidance document to look into this and make sure that change is possible and is efficient. So when we are in the hospitals, we as healthcare workers, we see ourselves as heroes, that we are there to save lives and be successful, and we are overachievers. But we all know the difficulties that we face when you're dealing with patients, when patients are treated by different disciplines or specialties in a hospital. So how exactly can we do, to make this, the work, that all this work that we do at global level, at regional level, to resonate at facility level, at hospital level? So I make this a table which I tried just to, to look into, three main areas. So one is surveillance, the other one is antimicrobial stewardship, and the last one is infection prevention and control. For the infection prevention and control, I will start from the bottom one. I want you to know that here includes everything. It's not only about the hand hygiene, but it's everything. As I mentioned in these slides, in my previous slides, is about the core components. So if we look at the what is needed at the hospital level, is to adapt and adopt IPC core components. So this is something that has to happen. So standard precautions are standard precautions. There is no big questions about that. But how to implement standard precautions? How to monitor standard precautions? How to make sure that standard precautions are actually well implemented? So this is something that has to be done at the hospital level. At the national level, for infection prevention control, they are defining the national guidelines. They are giving the national guidance. This is the IPC journey that we are taking in our country, and we recommend these measures to be implemented at facility level. So it's the national level responsibility. While for us here at the regional level, we are working to prepare and to support by, we are preparing these implementation tools that will support the implementation. At the global level, they are the ones who are definitely doing, giving providing the guidance and defining the guidelines. For antimicrobial stewardship, if we start from the global level, so we'll have these are very important. We have the priority.
Anna Paula, I'm sorry to interrupt, but we are now a bit behind schedule. Do you think you could conclude in 1 minute?
Yes, in 1 minute.
Thank you very much.
Thank you so much, and sorry. So for antimicrobial stewardship, we have the priority list, and then the list of essential medicines that needs. This is something that we do at global level. At regional level, we do the guidelines. national level, they will define the national guidelines. And at hospital level, you need to do it, adapt, adopt, and monitor and do an evaluation. For the surveillance, we know that surveillance for antimicrobial resistance, antimicrobial consumption, healthcare-associated infections are very important. So this needs to be, this comes as a guidance from the national level. The regional level can support to prepare these implementation tools, and at global level also defining what are the global trends and define global guidance. Thank you very much for this opportunity to have this talk with you. Apologies if I ran a little bit over my time, and I'm ready to take your questions. Thank you.
Thank you very much, Ana Paula, for this insightful presentation. We are running a little bit behind schedule, so I think we'll skip the Q&A session now, and if we have time at the end of the webinar, then we will revert back to you with a question from participants, because we received indeed a few questions for you. For the other participants that would like to ask questions to our panelists during the webinar, you can send your question to my colleague Maria, as indicated in the chat box that you will find in the webinar window. So thank you very much, Ana Paula, for this presentation. It is now time to move to our second speaker, Walter Sink, who is a senior physician with the Infection Control Program at the University of Geneva Hospitals. Walter is an expert in IPC, Infection Prevention and Control. He coordinated the Prohibit project, which stands for Prevention of Hospital Infection by Intervention and Training. It's a project that aims to understand existing guidelines and practices to prevent healthcare-associated infections in European hospitals. And Walter also played a key role as lead scientist in defining key components of IPC for the European Center for Disease Prevention and Control, the ECDC. So Walter, I'll upload your presentation now, and I will give you the floor so that you can start your presentation. And you should be online. Thank you.
Okay, thank you very much, Jean-Yves. Okay, so views on efficient and cost-effective IPC measures to address AMR in healthcare facilities in 10 minutes. Well, it's a bit ambitious, but I think I can tell you my view on that. First of all, I think you'll all agree that I have to make this a bit bigger. Okay, you all agree that we use a lot of antimicrobials. On this slide, you can see by country how many DDDs per 1,000 inhabitants are consumed or were consumed in 2015. And on the map above, everything that is red indicates that actually in those countries, more antimicrobials were consumed over time from 2000 to 2015. And what you can see, oh God. Does it work? Hello? Can you hear me? Okay, so what you can see here on this slide is that actually the driver to consume more antimicrobials comes mainly from upper middle income countries. So you can see here high income countries consume a lot of antimicrobials, but this has remained stable over time, while the upper middle income countries are and also the low middle income countries are the drivers to consume more and more antimicrobials, which will continue as such in the coming years. What is the strategy against it? Strategy against it is actually the antimicrobial stewardship. Antimicrobial stewardship has three groups of interventions. The first is say no to antibiotics, which means that, okay, use antibiotics only when really indicated. The second is use antibiotics wisely, means that adapt it to the treatment and choose initial treatment well. And then there's the third, prevent healthcare-associated infections. And basically, what I'm talking now is predominantly respect infection control measures. So what are the drivers, or how does infection prevention and control prevent AMR? Well, the first is here you can see the figure of an outbreak which happened in a neonatal unit in Cambridge, and you can see that many infants were involved, but also a healthcare worker was involved, and you also can see that there was transmission between children and family members. So I don't really understand in detail this figure, but you can see with the line, so that there's a lot of transmission going on. So one action of IPC to prevent AMR is to reduce transmission. And the second one is that you can see here over time, person multi-drug resistant pathogens and among Enterobacteriaceae in bloodstream infection isolates. And what you can see immediately is that there's the green curve, which is hospital onset, and there is the blue one, which is community onset. And hospital onset pathogens are more likely to be resistant. So one other factor how infection prevention and control reduces AMR is by reducing healthcare-associated infections, because those infections are more likely to be multi-drug resistant. So when we go one by one, we have transmission. So hand hygiene, glove use, workload. Let's start with workload. I mean, when we talk about the dissemination of multi-drug resistant pathogens in the hospital, we have to see that this is linked to workload, to stress. Here in this figure, in this table, basically, you can see a study in Slovenia where they linked the transmission of MRSA to the daily TIS score. Daily TIS score, which is a therapeutic intervention scoring system, which reflects stress, or no, which doesn't reflect stress, but workload. And you can see that the higher the workload, the more MRSA has been transmitted among the patients. And the next slide gives you a figure on what happened in a hospital in Malta. You can see the bed occupancy in gray and the MRSA infections in black. And what you can see here over time, we have seasonal variation, is whenever bed occupancy rises, there is, with a certain delay in time, there is also a rise in MRSA infections. So as well here, bed occupancy workload has an influence on the transmission of multi-drug resistant organisms. This slide explains you also partially why, because we consider hands as the main vehicle for transmission of multi-drug resistant organisms or pathogens in general. And you can see here, the more you need to do hand hygiene, the lower is the compliance. So in other words, to make it in summary, the more you have workload, the more you have stress, the less you are likely to do hand hygiene or other quality improvement measures. And in this slide, you can see that actually, yes, multi-drug resistant pathogens are contaminating hands or here gloves. And you can see here for MRSA, for BRE, for multi-drug resistant Pseudomonas and Acinetobacter baumannii, even if the hands were contaminated before room entering this study, where before and after patient care, hands or gloves were tested for the presence of multi-drug resistant organisms, you can see that the gloves after patient care were contaminated between 10 to almost 30% of those pathogens. So those pathogens, they do contaminate hands, and hands, if hand hygiene is not done correctly, or our hands are contaminated by removing gloves, as it's indicated here, and have a role in the transmission of these pathogens. On the other hand, if you can improve hand hygiene or can improve consumption of alcohol-based hand, as shown in this figure, you can reduce the transmission of multi-drug resistant pathogens. Here it is shown for extended spectrum beta-lactamase producing E. coli and Klebsiella species. Interestingly, the past ECDC point prevalence survey measured a number of indicators and was able to find this correlation here. You have on the y-axis what is called the Composite Index of AMR. The Composite Index of AMR basically is all the Enterobacteriaceae resistant to third-generation cephalosporins, all Pseudomonas resistant to carbapenems, all Acinetobacter resistant to carbapenems, all VRE and all MRSA together, grouped together. This gives a proportion of all such pathogens and how many of those are resistant, and this is what you find on the y-axis. And on the x-axis, you have the beds with alcohol-based hand drop dispensers. And what it shows, it's a negative correlation, which means that the more you have alcohol-based hand drop at the point of care, the less you have multi-drug resistant organisms in your hospital. When it comes to transmission, we think about isolation precaution measures. Well, isolation precaution measures are debated sometimes. I mean, there are more and more voices calling for caution to apply isolation precaution measures to too many patients, but undoubtedly, sometimes it is indicated. And here, for instance, we see a study from Israel. They had a large outbreak of carbapenem-resistant Enterobacteriaceae, which only was reverted when the Ministry of Health went to all hospitals in the country and they made sure that those patients were really put into isolation precaution measures, and also other safety measures were applied. The next slide, also again from the ECDC point prevalence survey, again the y-axis, you can see the Composite Index of Amr, again the proportion of multi-drug resistant organisms, and you can see here again a negative correlation to the number of beds or percentage or proportion of beds in single room of a hospital. So you can say, in other words, the more single rooms you have in a hospital, the less you have antimicrobial resistance, which is quite, I think, so clearly, it has probably has been shown so clearly for almost the first time. Healthcare-associated infections, well, yes, is hand hygiene effective also to reduce infections and multi-drug resistant organisms? Yes, it is. So this is the study by Didier Pité done in before 2000s, and shows that increased hand hygiene reduces healthcare-associated infections overall and also MRSA. The next study shows you a multifactorial action plan to improve hand hygiene adherence in an ICU, and together with other measures, you can see that actually the the catheter-associated bloodstream infections or central line-associated bloodstream infections has decreased over time thanks to those measures. From the PROHIBIT study, this was a multi-center study in 14 ICUs in Europe, and you can see here on this slide that hand hygiene has improved, and hand hygiene was associated not only because there were three arms. One was hand hygiene only, another was a bundle approach to prevent catheter-associated bloodstream infections, or the combination of the two. And you can see here in this slide, actually all three groups have significantly decreased the infection, but we also did a test of whether hand hygiene by itself had an impact, and this was statistically significantly correlated. Well, for cost, I think it is very difficult. I only want you to show this slide. This is a personal communication by Lindsay Grayson, who was in charge of hand hygiene in Australia. And what does it cost to improve hand hygiene? What does it cost to do standard precaution measures? And the hand hygiene in Australia costed about $3.20 per hospital admission, which is about 2/3 the price of a Big Mac. I already mentioned it briefly right now. The most effective for AMR prevention in hospital, which hand hygiene is. And the standard precaution measures are just considered the minimum of best practice procedures, and they should not be challenged in cost effectiveness discussions, in my opinion. Well, behavior change interventions do not need much technology, but I mean they do not cost nothing. That they do cost social investment, and they do cost an IPC team, and sometimes they also cost some salaries, because as you have seen before, higher workload results in transmission of pathogens and also multi-drug resistant pathogens. With this, I would like to thank you for your attention.
Thank you very much, Walter, for this insightful presentation. I think you covered a lot of things here. It's really interesting. We have limited time, but I will ask you 2 questions in one that we received. The first one is related to the fact that you said that the most effective measure to prevent AMR is to follow standard precaution measures. And the question we received related to that was what are the challenges to implement these measures at the hospital level? Why aren't they followed all the time? And the second question also we received was about more about geography, and the participant was wondering whether there were specific regions or countries that were leaders in preventing healthcare-associated infections. Thank you.
Okay, well, very shortly, the first question about standard precaution measures. I mean, standard precaution measures means hand hygiene, using personal protective equipment correctly, and so on, putting patients and then there are additional precaution measures such as isolation precaution measures. But standard precaution measures, actually, what is needed to apply them is certainly sufficient. To come back to the key components / core components, it needs staffing. I think it is clear that we need enough staffing that all those measures can be applied with all the patients when we are at risk of or exposed to multi-drug resistant organisms. And then the second one certainly is also material. And then we should never forget that since we are working in a complex environment and with a lot of procedures going on, that we always need to teach, to train healthcare workers to apply those measures in the different activities they do in daily practice. Then to come back to the second question, if there are some champions when it comes to being an example in the application of best practice procedures or reducing healthcare-associated infections, I think it's a bit difficult. Spontaneously, I would say that France did quite a good job by standardizing procedures, by having surveillance mechanisms in place in the country, and also in reducing antimicrobial use. Germany also reduced significantly their infections from the first to second ECDC PPS. Also Austria did the same. The United States, I have a bit of mixed feeling. I mean, there is the publication of reduced point prevalence of healthcare-associated infections published in the second survey recently, but there are some caveats to do this, but probably, I mean, generally we can say that the USA is certainly one of the leaders in applying best practice procedures.
Okay, excellent, and thank you very much for answering these questions. I think it's now time to move to our third speaker, who is Thomas Müller. Thomas is the environmental coordinator at the Aarhus University Hospital in Denmark. He's an environmental engineer by training, and he coordinates the approach to both waste and wastewater at Aarhus University Hospital. He has experience in mapping the sources of pharmaceutical pollution from hospital activities and developing technology to remove pharmaceuticals from wastewater. He recently collaborated with the Danish Technological Institute to investigate whether the use of parasitic acids can neutralize ciprofloxacin-resistant bacteria in untreated hospital wastewater. So, Thomas, let me upload your presentation. I'll give you the floor in a sec. And here you go, the floor is yours. Thank you very much, Thomas.
Thank you for the introduction, Sean. I am Thomas Müller from the Aarhus University Hospital, Denmark. I'm going to talk about neutralizing antibiotic-resistant bacteria directly in the sewer in the raw wastewater. I'm just going to move on here to the next slide. Just shortly about the agenda, a few words about the background for the project, something about the methodology, the injection of parasitic acids, a few words about the cleaning requirements, something about the laboratory testing results, something about the testing directly in the sewer, and then finally some conclusions from the project here. And regarding the background, here in Denmark, we are working with 2 different scenarios regarding the removal of pharmaceuticals from the wastewater. One scenario is that we treat the wastewater locally at each hospital, which is actually what the legislation here dictates at the moment. The alternative is that we treat the wastewater centrally and remove the pharmaceuticals and resistant bacteria centrally at the municipal wastewater plants. But we believe actually that if we do that, it will demand some disinfection of the wastewater by removing the antibiotic resistant bacteria from the wastewater before the wastewater leaves the hospital premises. And this, of course, in order that the resistant bacteria does not spread unnecessarily, which is, again, the reason for this whole project. And the next slide here. So what we are looking at here, or what we looked at in this project, was the case of injecting peracetic acid directly into raw wastewater. Would that work? Would that remove or neutralize the resistant bacteria? We knew already before starting the project that the peracetic acid has the ability to neutralize bacteria, but we needed to map the effect when injected directly into wastewater, since, at least to our knowledge, no one has actually done that before. So we conducted both some laboratory testings and some field testings on the matter, which gave us some data to actually draw conclusions on. And moving to the next slide here regarding the cleaning requirements. Actually, there are no legislation on this area at the moment, at least not here in Denmark. So the cleaning requirements here are based on a dialogue between us at the hospital and our local municipality. And we're focusing on ciprofloxacin-resistant bacteria, since ciprofloxacin is widely used both on a hospital and in the primary sector here at households. And so the requirements here for the reduction of resistant bacteria in the wastewater were set at the background level for normal municipal wastewater here. We have some measurings from a local wastewater treatment plant indicating what is the background level of resistant bacteria in wastewater when it's not under influence from hospital wastewater. So we use that as a benchmark, and we use that as a guideline to what level of resistant bacteria we have to decrease when we discharge wastewater from the hospital in the future. And then the final thing here is that the level of resistant bacteria must be reached before the wastewater actually leaves our premises. And that is that might actually be quite the challenge here, because from the wastewater leaves the toilets or some other location in hospital buildings until it actually leaves the premises of the hospital, we do not have many minutes. So the chemical reaction has to run quite quick. And so we have to adjust the amount of peracetic acid added to the wastewater with this in mind. And so moving on to a slide here on our laboratory testings based on samples directly from the sewer at the Aarhus University Hospital. In the illustration here, you see a blue line on the resistant bacteria in, as it's called, VBU. That's a part of Aarhus. It's a wastewater treatment plant, municipal. The special thing about this municipal wastewater treatment plant is that it does not receive wastewater from industry or hospitals. It's only from the primary sector. So this value measured here of resistant bacteria is a benchmark for our work. And for our test in the laboratory, you can see that we have used different doses of peracetic acids, varying from, for instance, 50 milligrams per liter until 100. And then we've been measuring the reaction in different time frames, for instance, 10 minutes, 20 minutes, 60 minutes. And so you can see all of our testing here indicates that it's definitely possible to remove the resistant bacteria from the wastewater. The question is only what concentration do we need and how much time do we need. And so this is basically, this just tells us that it's definitely possible, but we still needed to test it in the sewer, in the raw wastewater. And moving on here to the slide, this is a couple of pictures just to show where we were working and how we were working. We're pumping up raw wastewater directly from the sewer, of course, and then pumping it into this blue tube that you see in the middle picture here. In this blue tube, we have some water taps installed at designated places. because we were able to control the flow of this tube. And so when we tapped some water at a certain place, we knew that it had been underway for 2, 3, 5 minutes. And so we could get some specific results on how much we had reduced the amount of resistant bacteria after a certain amount of time with a certain concentration of peracetic acid. And this actually leads forward to the next slide here, where you can see in the picture there's a small writing in yellow on the tube there indicating 5 minutes. So this water tap is placed where the wastewater and the peracetic acid has been underway for 5 minutes. So we can see with a certain concentration of peracetic at this place, we have this amount of resistant bacteria left. And the conclusions here from the real testings in the field indicating that that it does work. So the testing confirms what we have from the laboratory. And the challenge here is only actually that we do not have that big a time frame, but our conclusions from the testings is that we need between something like 83 and 115 milligrams per liter per acetic acid added and injected into the wastewater to actually reduce the number and the amount of resistant bacteria to under the baseline that I was talking about from the municipal wastewater plant before. And then moving on to conclusions here. Overall, the conclusion is that this methodology works and that resistant bacteria can be neutralized locally at hospital by injecting the peracetic acid directly into the wastewater. The aim of this project was proof of concept, and so we have it include mapping on correspondence between SSARB as antibiotic resistant bacteria in the wastewater and the amount of peracetic acid needed to actually neutralize the resistant bacteria in the wastewater. So local tests on other sites will need to be conducted to determine the needed concentration of peracetic acid to actually reach desired levels of resistant bacteria. So finally, this is not a final guideline, this project and the conclusions from this project, but it provides a documentation that injection of peracetic acids in wastewater actually is way forward. It's a methodology that actually works. And should you be interested in more knowledge on the matter, you can reach out for the report. It's in English, so it should be readable for most of you. You can get it from either contacting me. You can reach me at this email address, or I'm sure that Sean and the other members at HCWH can be helpful there as well. So finally, just thank you for listening, and please, if you have any questions, don't hesitate to contact me. Thank you.
Thank you very much, Thomas. And actually, my colleague Maria just added in the chat the link to the report you just mentioned. So if people are interested, they can, of course, read it. As you said, it's in English. So that's perfect. A first question that we received, one of the participants was wondering whether peracetic acids could also be used to neutralize bacteria that were resistant to other antibiotics. Because we know, for instance, that ciprofloxacin is a broad-spectrum antibiotic, but could peracetic acid also work on narrow-spectrum antibiotics, for instance?
Yes, I would definitely expect so, but I don't have the documentation that supports it. We chose ciprofloxacin because it's widely represented both in the primary and the secondary sector. I'm quite sure, I can't guarantee it, that we will see the same picture if we choose other resistant bacteria. I mean, bacteria that are resistant to other antibiotics, but it would have to be investigated more to be certain.
Okay, so it's very promising indeed. Another participant was also wondering why there was no other wastewater disinfection method that were used, for example, UV light ozonation. Why were these ones put aside in this pilot project?
Well, the chemical ozonation, for instance, with ozone or other chemicals, that's another way of treating wastewater. That we would use that if we wanted to a complete cleaning of the wastewater, a total treatment, where we want to discharge clean wastewater or waste or water from the hospital. This is only focused on neutralizing the resistant bacteria and nothing else. The other thing would be a full treatment, and that's something different if you start doing that. And then ozone is also a bit more expensive, to my knowledge. It's a bit more complex to use. So this is really focused on only the resistant bacteria. We can use the other thing as well, but that's another task. If we want to clean, treat the wastewater locally at the hospital for full treatment, then ozone will be a natural part of that. But that's not the issue here. That's another issue. That's another talk, in my opinion.
Okay, thank you. You were talking about cost actually. What is the cost of implementing this project, and how can it be scaled up across various hospitals in Europe?
The cost, we haven't calculated a final price for implementing yet, but I would assume that something between 100 and 150,000 euros for establishing it. And then there's the ongoing running cost, and how big that is depends, of course, on the concentration of the peracetic acid. The lower the concentration, the cheaper it will be to run it. But so what I can tell you now is that we expect something like 100 or 150,000 euros to establish locally at hospitals. To compare, for instance, with a full treatment, that here would be something like 3 or 4 million euros, and that's a significantly different price. That's why we're looking at it, because this is much cheaper. We can get away with just treating the resistant bacteria locally and then treating all the pharmaceuticals at the central municipal wastewater treatment plant. That will be much more efficient also from an environmental point of view, but that's a whole different story. I got lots of data about that, but I don't think we have time for that right now.
Thank you very much. And just a last question. Someone is wondering whether the use of peracetic acid would not have an impact on climate change or on environmental impacts.
Well, it disappears actually quite quick. It reacts with the suspended stuff quickly in the sewer. We've been looking at that. So within a relatively short time frame, it's gone. The peracetic is gone. It has reacted with the suspended stuff in the wastewater already before it reaches the municipal wastewater plant. That is our conclusions, at least. So no, it does not infect on the environment because it's gone before it reaches that.
Okay, excellent. Thomas, thank you very much. I think it's really promising, and we look forward to seeing how this could be scaled up in the future for sure. I think it's now time to move to the last section of our webinar, where I will present the outcomes of a report tackling AMR in Europe's healthcare facilities that we are publishing today. I'm sorry for participants, we're a bit behind schedule, but I'll try to be quick. So as you know, healthcare facilities are hotspots for the development and spread of drug-resistant bacteria. And according to a study that was published in the Lancet journal, 75% of infections with drug-resistant bacteria in Europe are actually associated with healthcare. And according to figures put forward by the ECDC, multi-drug resistant bacteria are a leading cause of the 8.9 million annual healthcare-associated infections in Europe. So recognizing this issue, Healthcare Rotterdam Europe launched in 2019 a survey to identify best practice for tackling AMR in hospitals across Europe. And the subsequent report, which is based on the survey, makes recommendations in 5 areas: antibiotic stewardship, IPC, wastewater treatment, procurement practices, and training and information. There were 6 hospitals or healthcare centers that took part in the survey: the Aarhus University Hospital, the Centre Hospitalier de Niort in France, the Lazzaro Spallanzani National Institute for Infectious Diseases in Italy, the National University Hospital of Iceland, and 2 hospitals in the UK, the Royal Infirmary of Edinburgh and the Sussex Community NHS Foundation Trust. So the first area that was observed is related to antibiotic stewardship. So we know that there's only 10 to 20% of all antibiotics that are used in hospitals in comparison to the community. However, the intensity of use is much higher in hospitals than in the community. Also, hospitals are usually where last resort antibiotics are used. And according to the OECD, up to 50% of all antimicrobial consumption in human healthcare may be inappropriate, but this could be higher and rise up to 90% in certain cases. So in a survey to the 6 hospitals I mentioned before, antibiotic stewardship was identified as a main action to address AMR within their hospitals. And a few recommendations that came out of their practice, there were 4 of them. The first one is to involve infectious disease specialists in decision-making processes when we prescribe antibiotics in the case of drug-resistant infections. 2, to make prescriptions of broad-spectrum antibiotics conditional to strong pharmaceutical control in order to make sure that we safeguard the effectiveness of these antibiotics when we treat severe infections. 3, to make the best use of technology via applications, e-learning modules, and intranet to facilitate access and dissemination of prescribing guidelines. And finally, to undertake regular reviews of antibiotic prescriptions to reduce and curb the inadequate or inappropriate use of antibiotic. The second area that was addressed in the survey is related to infection prevention and control, or IPC, because we know that IPC helps prevent infections that would otherwise require further treatment. However, basic measures that can play a significant role in preventing the spread of bacteria between patients are often neglected, which is something also that Walter has highlighted in his presentation. However, in the survey, we decided to focus on whether hospitals were taking steps to improve sanitation infrastructure to prevent the spread of drug-resistant bacteria. And we have to admit that the results were kind of mixed because most respondents were unaware of projects that were in the pipeline. However, there were 4 recommendations that were put forward. The first one was to encourage continued cooperation between IPC teams as well as antimicrobial pharmacists in order to prevent healthcare-associated infections. 2, to develop and also implement healthcare-associated infection prevention bundles in order to improve prevention effectiveness and patient outcomes. 3, to develop standard operating procedures, or SOPs, in order to ensure the hygiene of isolation rooms for patients that are infected with multi-drug resistant organisms. And the fourth one was to prioritize single occupancy patient rooms when we decide to build new healthcare facilities. Of course, this has a short-term cost, but it allows to alleviate the long-term AMR burden. Then the third area that was addressed in the survey and the report is related to wastewater treatment. As you may know, 30 to 90% of all pharmaceuticals that are administered orally are actually excreted into wastewater as active substances. And if it's true that if antibiotics are widely used outside healthcare facilities and that just 10% of medicinal products in urban effluents come actually from hospitals, there is, however, evidence that hospital effluents have an important impact on the prevalence of drug-resistant bacteria for some specific antimicrobials. And ciprofloxacin, which Thomas just mentioned, is one of them. In our survey, we noticed that there was actually little involvement from the hospitals we took part in the survey in terms of wastewater treatment practices outside the Aarhus University Hospital. So the 2 recommendations that came out of the survey in this area were actually coming from Thomas. And the first one was to measure the concentration of AMR in hospital wastewater in order to be able to compare it to the concentration of AMR in local municipal wastewater in order to determine the need for action. And the second recommendation was to take part in pilot projects in order to reduce upstream discharge of antimicrobials that contribute to high levels of resistance in hospital effluents. The fourth area that was addressed in the report was related to procurement practices. For the time being, China produces between 80 to 90% of antibiotic active pharmaceutical ingredients, what we call the APIs, while India is actually the leading producer of the finished dose products. And these 2 countries have weaker environmental standards than those that are enforced in the EU. And there has been evidence in the past of large-scale environmental pollution. And this is a big issue because manufacturing pollution, as you know, is driving the emergence of drug-resistant bacteria that are then spreading around the world through trade and travel. Just to give you an example, there was a study that was published that showed that between 70 to 90% of travelers to India are actually coming back with drug-resistant bacteria in their guts. These countries are, of course, supplying the EU market, so the EU is also partly responsible for this global pollution. And there is something that the European healthcare sector could do about it. In our survey, we showed that there is a growing awareness in terms of what's happening in the manufacturing conditions that occur in developing countries that produce our drugs. However, there was only one respondent at this stage that included environmental criteria in pharmaceutical procurement practices. The recommendations that were put forward was one, to mobilize the economic and ethical influence of the healthcare sector in order to transform the pharmaceutical production chain. And we can see the possibility to use the EU Public Procurement Directive to do so. Two, to include environmental criteria in pharmaceutical procurement in order to support informed decision-making when we purchase new drugs. And finally, to raise the issue of pharmaceutical manufacturing pollution with policymakers and to advocate for strengthened environmental regulations. Finally, the last area that was addressed in the report is related to training and information. Of course, training healthcare workers is crucial when we're talking about addressing AMR in healthcare facilities, and there is a need to include more AMR in education schemes, especially in the area of adequate use of antimicrobials and in patient management. The fight against AMR, of course, requires a multidisciplinary approach, so it should not only be the prerogative of medical doctors, but should also be the prerogative of nurses who are in direct contact with patients, as well as to hospital pharmacists. In our survey, we showed that most respondents actually organized already training for healthcare workers, and some of them are also providing materials to raise awareness among patients. Three recommendations that came out of this area. First one, develop multidisciplinary training programs. Two, to provide prescribers annually with a defined daily dose ward profile in order to benchmark and control the amount of antimicrobials that are prescribed. For those who don't know, the defined daily dose is a measure that has been defined by the WHO to allow for comparisons of drug consumption between countries. And the last recommendation was to organize awareness-raising activities and provide patients with information on medication compliance and proper antimicrobial use. As a conclusion, we show in a report that there was a high level of awareness on AMR among respondents. However, the results showed as well that healthcare facilities could make better use of the wide range of tools that they dispose, especially in the area of procurement practices and wastewater treatment. As we know, measures come at a financial cost, so there is a need for more public funding to help accompany hospitals to address AMR. However, investment could also be cost-effective, and I will conclude by this figure coming from the OECD, which says that 3 out of 4 deaths that are attributable to drug-resistant infections could be averted by an annual spending of only $2 per person on measures as simple as hand washing or prudent prescription practices. So thank you very much for listening to this recommendation. You can find these recommendations in more detail in our report, which is out now and which is available on our website. So it is now time to conclude our webinar. I would like to thank you very much for following this webinar. Thank you, of course, to our 3 speakers, Anna Paula, Walter, and Thomas, for the time and insightful presentations. And if you'd like to be kept informed of our activities, you can go to the following link to subscribe to our newsletter and our Safer Pharma Bulletin. So the next appointment with the Safer Pharma program is a workshop on pharmaceuticals in the environment that will be held on the 12th of November in Brussels. And if you'd like to join or have more information, you can just access it on our website, nohameurope.org. Many thanks once again for participating, and I look forward to seeing you next time.